So the heart has its own specialized muscles that are capable of generating a nerve impulse, which causes the heart to contract. Now, the heart muscles spontaneously respond to some changes in electrical signals to contract, and the contraction the rate of heartbeat depends on the atrial cells and the ventricular cells. The atrial cells beat at 60 times per minute and the ventricular cells beat at 20 to 40 times per minute. And for the intrinsic conduction system, all these cells function together, and we also call it the nodal system. So the intrinsic conduction system is controlled by two things, or regulated by two things, not controlled. The autonomic nervous system. Now, the autonomic nervous system can be of two types. Sympathetic, which is responsible for the fight or flight response. So anything to do with sympathetic nervous system stimulates the heartbeat. So there is hormones secreted by the sympathetic nervous system, like epinephrine and norepinephrine. So I'm going to write this down. So for sympathetic nervous system, hormones like epinephrine and norepinephrine stimulate the heart rate. And the parasympathetic nervous system it lowers the heart rate. So a good example of a hormone that reduces the heart rate is acetylcholine. So acetylcholine helps in slowing the heart rate. So I'll write that down too. Acetylcholine. All right. So the intrinsic conduction system is also known as the nodal system. We'll see why. Now, this particular system sets the rhythm of the heart, and it's composed of specialized nervous tissue that depolarize. Now, depolarization is a process in which the cell that is normally negatively charged becomes positively charged on the inside, and the outside of the cell becomes more negatively charged compared to the inside of the cell. So this causes a generation of an electrical impulse that is transmitted through the specialized cells of the heart and causes a heart rate of about 75 beats per minute. Now, the components of the intrinsic conduction system include SA node, which is also known as the sinoatrial node. Now, sinoatrial node is a bundle of specialized cells that are capable of generating their own electrical impulse. So this is called the pacemaker of the heart. And the heart does not need a signal from the brain to start beating, regardless, as long as the muscle cells in the heart, the specialized cells in the heart are capable of generating a nervous impulse. They will continue to generate an electrical impulse. So the SA node is located in the right atrium. So the depolarization begins right at the SA node. And the next node is the AV node. AV node is present in between the atrium and the ventricle. So this node is capable of generating an impulse on its own. And then you have the bundle of His or the bundle branches present in the interventricular septum, which is the wall between the two ventricles. And then Purkinje fibers are really tiny fibers which are spread across the wall muscles of the ventricles. So either way, regardless of what begins the electrical impulse, whether it's SA node or AV node. In the end, it reaches the Purkinje fibers to make the ventricle contract. All right. So this picture shows the intrinsic conduction system. Right over here, you see the sinoatrial node. So the heartbeat begins right over here. So keep in mind the SA node is present in the right atrium. And the SA node generates an impulse which is shot across to the left atrium. And at the same time, the impulse is transferred to the AV node. The AV node receives the signals and the impulse is held there briefly. And when this happens, the atrium contracts. So it squeezes blood through the valves into the ventricle. And to allow enough blood to be squeezed into the ventricles, there's a slight delay in the transmission of the electrical impulse by the AV node. Now, after a few milliseconds, the impulse travels through the bundle of His. The bundle of His further divides into the bundle branches. So these are the bundle branches. The bundle branches further divide into smaller Purkinje fibers. Now, when the Purkinje fibers finally receive the electrical impulse, the ventricles contract and the blood is ejected from the heart, either through the pulmonary trunk and, well, not either, to the pulmonary trunk, through the pulmonary trunk and through the aorta. So these ventricles contract simultaneously, and from the left ventricle, blood is pumped to different body systems. So this side is involved in systemic circulation, whereas the right side of the heart is involved in pulmonary circulation, because from the right ventricle, blood is pumped to the lungs for exchange of gases. So for an adult, a normal resting heart rate will be in the range of 60 to 100 beats per minute. And the first condition is tachycardia. So tachycardia is a condition in which the resting heart rate is above 100 beats per minute. And bradycardia is a condition in which the heart rate drops below 60 beats per minute. So in trained athletes, they typically have very low heart rates. So if the patient is not exhibiting other symptoms like weakness, fatigue, fainting, chest discomfort, etc., it's not really, bradycardia is not considered clinically significant. So bradycardia can also be caused due to other inherent factors, which may either include abnormalities in the SA node or the AV node. And if the condition is serious, a pacemaker might be required. And some other causes may be due to metabolic disorder that affects the endocrine system. Now, tachycardia is not normal in a resting patient. But tachycardia is detected in pregnant women and individuals that experience extreme stress. But keep in mind that the resting heart rate of a normal person can be anywhere between 60 to 100 beats per minute. So the cardiac cycle refers to the period from the beginning of one's heartbeat to the beginning of the next. So there are two phases of the cardiac cycle. The first one is systole, which it means contraction of the heart, and diastole, which causes relaxation of the heart. So during contraction, now at the beginning of systole, meaning contraction, the ventricles contract, and the increasing pressure of the ventricle forces the AV valve to shut close. So the valves between the atrium and the ventricle shuts close when the ventricles contract. And The semilunar valves, that is in the pulmonary trunk and the aorta, they open. And as the ventricles contract, the ventricular pressure rises, and the semilunar valves are, forced open. And when this happens, blood is ejected into the aorta and the pulmonary artery. Now, the next phase, which is diastole. Now, during diastole, the ventricles empty and relax. So the ventricular pressure during diastole or relaxation falls below the pressure of the pulmonary artery and the aorta. Now, at the beginning of diastole or relaxations, the semilunar valves close to prevent backflow of blood into the ventricles, and instead of the semilunar valves, the atrioventricular valves, they open up to allow blood flow into the ventricles. So during ventricular relaxation, there's passive flow of blood from the atrium into the ventricles. When the ventricles become full, near the end of this phase, the atria contract to squeeze the remaining blood into the ventricles to start a new cycle. Now, during the first step, the atrial diastole, this leads to ventricular filling. Keep in mind, diastole means the heart is relaxed. When the heart is relaxed, the AV valves, that is the atrioventricular valve, are open and blood passively flows into the right and left ventricles. So we call this ventricular filling or atrial diastole. Both of them happen simultaneously. And the next step is atrial systole or atrial contraction. Now, during atrial contraction, the atrium squeezes to fill up the ventricles and squeeze out the remaining blood from the atrium. And the next step is isovolumetric contraction. Now, in response to the rise in pressure due to the blood in the ventricles, the rise in pressure leads to the close in the AV valve. So you can see that the tricuspid valve right over here and the bicuspid valve, they shut close to prevent backflow of blood into the atrium. And this in turn leads to the opening of the pulmonary semilunar valve and the aortic semilunar valve. So the pulmonary semilunar valve and aortic semilunar valve are still closed. This phase is called isovolumetric contraction. So during isovolumetric contraction, the rise in pressure in the ventricle leads to closure of the mitral and the tricuspid valve. So the next step is ventricular systole or ventricular ejection phase. Now, when ventricular pressure exceeds the aortic and pulmonary arterial pressure, the semilunar valves are forced to open and the ventricles eject blood through the pulmonary arteries and the aorta. Now, the last phase is called isovolumetric relaxation. Now, when the pressure of the ventricles fall below the pressure in the pulmonary trunk and the aorta, the aortic and semilunar valve, they shut close to prevent blood from flowing back into the ventricles. So during isovolumetric relaxation, all valves are closed. So you can see that the atrioventricular valve are closed and the semilunar valves are also closed. So atrial diastole occurs as the blood fills the atrium, meaning the heart begins to relax. So the heart sounds that you hear when you place a stethoscope near the heart is lub-dub, lub-dub. So the lub sound is caused by closing of the AV valves, which is the tricuspid valve on the right and the mitral valve on the left. Now, dup sound is a short, sharp heart sound which is caused by closing of the semilunar valves, which is at the end of the ventricular systole or contraction. So the cardiac output can actually tell us how efficient the heart is, and the cardiac output refers to the amount of blood the heart pumps in 1 minute. So this is equal to the heart rate multiplied by something called as the stroke volume. Now the stroke volume depends on several factors that we won't go into right now, but just keep in mind cardiac output is the heart rate times the stroke volume. Now the stroke volume in general is the volume of blood pumped by each ventricle in one contraction, meaning with each heartbeat, how much volume of blood is pumped by each ventricle. So in general, about 70 ml of blood is pumped out of the left ventricle with each heartbeat. So if you look at the calculation, cardiac output is the product of the heart rate and the stroke volume. So if the resting heartbeat is 75 beats per minute and the stroke volume is 70 ml per beat, the cardiac output is equal to 5250 ml per minute, which is equal to 5.25 liters per minute. So this is an average cardiac output in a normal person at rest. There are several factors that influence basic heart rate. First is the nervous system. You can have the sympathetic nervous system. Sympathetic nervous system, as we discussed before, speeds up the heart rate and affects the cardiac output. So if it speeds up the heart rate, the cardiac output will be increased. On the other hand, when the parasympathetic nervous system is active, it calms or reduces the heart rate. It has an opposite effect. So parasympathetic nervous system reduces the heartbeat, and when the heartbeat reduces, the cardiac output also reduces. Now there are some other things like hormones and ions that affect the heart rate. Now epinephrine is a hormone that increases heart rate. It has a stimulatory effect, and this in turn increases cardiac output and stroke volume. Now, when a person has high blood pressure, the sympathetic nervous system takes over, and the sympathetic nervous system causes the increase of heart rate and increase of contractility of the heart. So when a person exercises, you see a similar effect because the skeletal muscles start squeezing the blood vessels to increase venous return of the heart to the heart, and it also increases respiratory pump. So both the skeletal muscle and the respiratory pump together increases the amount of blood that is being pumped back to the heart, thereby increasing the stroke volume. Keep in mind the cardiac output is the heart rate times the stroke volume. So the cardiac output is directly proportional to the heart rate and stroke volume. Okay. So when there is decreased blood volume, which can cause a hemorrhage, and this leads to decreased venous return. When there's a decreased venous return, there's not enough blood returning to the heart. So when there's not enough blood returning to the heart, it leads to lesser stroke volume because there's not as much blood entering the heart. So you have a lesser cardiac output. So there are other things like ions that influence the heart rate. For example, calcium, sodium, and potassium ions are major ions that modify heart activity. Excess calcium is called hypercalcemia. So hypercalcemia decreases heart rate and contraction strength, And hypocalcemia, which is a deficiency of calcium, increases heart rate and contraction strength. Now, potassium ions has the greatest effect on heart rate. So anybody who has a lab report with fluctuating potassium ions or hyper or hypokalemia, which is excess potassium ions or really deficient concentration of potassium ions, they're always hooked up to an EKG. Hyperkalemia means excessive potassium ions, and this condition, the myocardium becomes less excitable, and when the myocardium don't get excited, the heart rate slow down because it's not generating enough impulse. The heartbeat becomes irregular. Now, in hypokalemia, which is deficiency of potassium ions in the cardiocytes, the cells become hyperpolarized, so it increases the stimulation of the heart. There are other factors like age, gender, exercise, body temperature. All of these play a very important role depending on the wear and tear of the cardiac muscles and the blood vessels that pump blood to the heart. So there are several factors that influence heart rate. So there are obviously a lot of blood vessels associated with the heart itself. So the cardiovascular system is made up of the heart and the associated blood vessels. And the blood vessels form a vast network that transport the oxygenated blood to the tissues, and they bring back deoxygenated blood back to the heart. So the vessels that carry blood away from the heart are called arteries, and the only exception, the arteries are usually highlighted in red because they carry oxygenated blood. So the only exception where arteries carry deoxygenated blood is the pulmonary artery. But keep in mind, the correct definition would be that arteries carry blood away from the heart, and the only exception is the pulmonary artery. And the arteriole are the smallest arteries, and these arterioles further branch to make really tiny capillaries. Capillaries are really thin blood vessels. This is where the actual exchange of nutrients and waste occurs. So these arterioles form capillaries, and these capillaries further form venules. So the venules are small blood vessels that carry blood to the veins. Now the veins are blood vessels that carry blood towards the heart. For the most part, veins are highlighted in blue because the blood returning back to the heart is usually deoxygenated. The only exception to the veins wherein you find oxygenated blood is the pulmonary vein. So the left and right pulmonary veins carry oxygenated blood from the lungs to the heart. So this over here is a histology slide of the arteries and veins. You can tell a clear difference when you look at the artery and vein. So the arteries, when you take the first look at the arteries, you can see that they have really thick walls and really small lumens, and they generally appear rounded. Now the reason they do have thick walls is because blood in the artery are present under really high pressure. Now the veins, on the other hand, have really large lumens, and they generally appear flattened. Now, if you look at the detailed structure of the artery and vein, so both of them contain three layers: tunica intima, which is the innermost layer, tunica media, which is the middle layer, and tunica externa, which is the outermost layer. Now, the tunica intima is made up of endothelium. Uh, Endothelium is basically a layer of simple squamous epithelium, uh, which is then in turn connected to a lot of loose connective tissue. So the endothelium usually appears wavy in a histology slide due to constriction of the smooth muscles. And it contains internal elastic membrane in really large vessels. So you have the internal elastic lamina. So all three together make up the tunica intima. So you can see the tunica intima is present in both the arteries and veins, but the loose connective tissue is thicker in the veins than the arteries. Now, the endothelium in the veins usually appears smooth because there's not a lot of smooth muscle which is trying to constrict the blood vessel. And then it also has an inner elastic membrane. Okay, sorry, it does not have an inner elastic membrane. So the artery, on the other hand, needs to be really elastic because the blood forces itself through the arteries under really high pressure. So the tunica media is the middle layer. The tunica media is the thickest layer in arteries, and normally the tunica media in the arteries is thicker than the veins for a reason, because again, this particular blood vessel, which is the artery, needs to withstand a lot of pressure. So the tunica media is made up of a lot of smooth muscle and elastic fiber. Again, the tunica media is wrapped by an external elastic lamina to help with elasticity when blood flows through the artery. So the smooth muscles, elastic fibers, all of these vary with distance from the heart, because the muscles that are closer to the heart in the tunica media will need to withstand higher pressure than, say, the smooth muscles of tunica media in your feet. So the thickness of the smooth muscle varies based on how far they are from the heart. Now, the externalmost layer is called tunica externa. The tunica externa is normally thinner than the tunica media, but it is it is made up of collagenous and elastic fiber. Normally, this particular layer is the thickest in veins, and it's made up of collagenous and smooth fibers, which is made up of smooth muscles. Now, if you observe one important difference in the arteries and veins, you can see that the veins have valves in them, but the arteries do not. Now, this valve over here prevents the backflow of blood when blood is moving towards the heart. Just imagine these muscles in the veins. They don't have too much pressure in them, right? So they do not have too much pressure when blood flows through the veins. So these valves help in moving the blood towards the heart, and they prevent backflow. Now, the thinnest blood vessel is the capillary. Now, capillary is a blood vessel where the actual exchange occurs, the actual exchange of nutrients and gases. So this particular blood vessel is made up of a very thin layer of epithelial cells, simple squamous epithelium, and surrounding the endothelium, you have the basement membrane. So one condition that you can associate with blood vessels is the presence of varicose veins. So what happens is that despite the presence of valves, inevitably some of the blood can flow back due to gravity. So in clinical conditions, this particular backflow causes edema, which is something beyond normal swelling. So edema is basically accumulation of fluid. So edema is sometimes accompanied by varicose veins, especially in the superficial veins of the legs. This condition is more common in women than in men. So pregnant women often experience the presence of varicose veins. So what happens in varicose veins is that the valves become defective and it allows blood to accumulate within the veins. And this causes the backflow of blood, and the veins become twisted and visible on the surface of the integumentary system. In some people, this is painless, whereas in other people, it's often painful and sometimes really, really itchy. Now, these conditions can be treated by laser surgery and a lot of radiological procedures. So right over here, you see capillary blood, and you see arterioles, which give rise to something known as meta-arterioles. So meta-arteriole is a type of blood vessel that has the characteristic of both an arteriole and a capillary. They are slightly larger than a typical capillary. Now, in this capillary bed, you see something called as precapillary sphincters. Precapillary sphincters are circular smooth muscles that surround the capillary at the region where it joins the meta-arteriole. Now, their function is really critical because these precapillary sphincters are not open all the time. In general, they're actually closed, because if they're open all the time, they'll collect every blood in the body and there'll be none left in the arteries or the arterioles or the veins. So there would be no blood in the heart itself. So these precapillary sphincters only open up when it needs to allow blood to flow through to allow exchange. Say, for example, when you are working out, the muscles need a lot of blood supply and they generate a lot of waste products. So the precapillary sphincters in the muscles open up. On the other hand, the kidney and the digestive system, shuts off its precapillary sphincters, because while you exercise, you don't need so much energy that is being wasted on digestion. So you don't need so much blood supply for the digestive muscles. So the precapillary sphincters in the muscles open up, the skeletal muscles open up, and the precapillary sphincters in the digestive system shuts off. So when the precapillary sphincters are closed, the blood flows through something called as a vascular shunt. So if the precapillary sphincters will just flow from the meta-arteriole directly through a channel, well, this particular condition where the passage of blood into the surrounding capillary bed is blocked is known as a vascular shunt. So in this case, the additional branching or anastomosis, they do not get any blood. So the blood directly passes through the meta-arteriole from the arteriole to the postcapillary venule.